It's my pleasure and honor to present Professor Neil Poulter from Imperial College in London. Professor Poulter was the past president of the British Hypertensive Society and the International Society of Hypertension. He also has over 650 peer-reviewed articles, and he'll be talking to us today about the optimal drug sequencing for cardiovascular protection.
Thank you very much indeed. Good afternoon, ladies and gentlemen. Once again, I'm delighted to be here still. And over the next 25 minutes, I'm going to talk to that slide about the optimal. Sorry that half the slide isn't visible, but there we go. I'm going to talk about what I think is optimal drug sequencing for cardiovascular protection. And obviously you understand in hypertension that would normally take several hours. We could talk about all the drug classes for an hour each, but we're going to skip through this in 25 minutes. Same conflict of interest. I hope I haven't got one, but I show it for political correctness. And now, once again, I'm sorry you can't see this. The chairs are in the way, but here you see what's happening around the world. And what you see is that the world has almost doubled the number of people with raised blood pressure on the left-hand side there, between 1990 on the left and 2019. So in about 30 years, you've almost doubled the number of people with high blood pressure. And this color scheme, the red ones, are those that are undiagnosed. The majority of the world's hypertensives are undiagnosed. Treated and control is the dark green at the top. So that's a small proportion. Now, if you focus on the two boxes to the right, you can't see the one on the bottom right-hand side, and that was lunch. You see the two ones, including Africa. You see the big increase in the numbers is happening in Middle East and North Africa and Sub-Saharan Africa, big numbers. And particularly in Sub-Saharan Africa, the red bit, the undiagnosed ones, are clearly the majority of hypertensives. So that's got big implications for what we need to do, and that is we need to increase screening for blood pressure. There we go to Sub-Saharan Africa, and there it gets bigger. I'm not quite sure why that happened. Now, what should we be doing? Well, this was a very good quote from the British and Irish Hypertension Society nearly 20 years ago, that monotherapy is usually inadequate therapy. And around the world, the majority of hypertensives, if they are treated, get one drug class. And yet we've known this for over 20 years. You need more than one drug class to get the blood pressures controlled to conservative targets. And that's reflected in the recent guidelines. You see on the bottom right-hand side, I'm sorry, once again, hiding behind the chairpersons, is PASCAR, European, ISH, and WHO. All those guidelines in the last 4 or 5 years have said the same thing. First of all, we should probably be starting our treatment with 2 drug classes, and we should probably be using those 2 drug classes, if we can get them, deliver them as a single pill combination. Okay. Why single pill combinations? Well, 5 reasons. The first is that single pill combinations are more effective and they give more rapid blood pressure control than monotherapy does, or with the 2 same drugs in your single pill given separately, because the patients don't take them as carefully. Secondly, 2 low doses of drugs in the same pill give you less side effects than monotherapy at full dose. That all improves adherence. Fewer side effects, the fewer number of drugs, the more likely they are to be taken. And if you take the tablets, the last 2 bullets, you're going to get improved cardiovascular protection, and that inevitably will be more cost effective. So that's why the guidelines are saying use single pill combinations. The next question is, what combinations, what drugs should we use together? Well, here you see the European guidelines of 2018, and opposite the green pill, you'll see, ideally, a single pill combination. You see, the Europeans recommend an ACE or an ARB, so a RAS blocker plus either a calcium channel blocker or a diuretic. So that was the European guidance in 2018. 2 years later, the International Society of Hypertension came out with a variation on that, but you can see on the left-hand side, ideally single pill combinations. If we can get them, that makes sense to use. But then go up to the top right, step one. They've made it simpler. They said start with A plus C. A is, as you see at the bottom, is an ACE or an ARB. It's easy to remember. A is ACE or ARB. I'll come back to that choice later. Plus C, dihydropyridine calcium channel blocker. So that's what they recommend as the go-to combination around the world. But notice at the top right, there are a few footnotes. And if we highlight those footnotes, the second one I want you to focus on is that you might also consider A plus D. So RAS blocker plus diuretic, where the trial evidence says they work. And that's post-stroke in the very elderly, incipient heart failure, and those with CCB intolerance. So they're quite similar to the European guidelines. A plus C or A plus D is what the Europeans said, and ISH have agreed in certain subgroups of patients. Now, most recently, WHO, they too have come up with starting with combinations of drugs. And they've made it a bit easier, if you like, but they've said the same thing. Either use a thiazide or a thiazide-like. Now, I just want to stress this, I'm going to come back to it. They are not the same thing and should not be confused. I'll come back to that and tell you why we should be using thiazide-like and not thiazides. A, ACE or ARB. Once again, I'll come back to the data that persuades me that we should be using ACE preferentially for ARB, and then C, long-acting dihydropyridine calcium channel blockers. So any two of those three is what they suggest. And once again, at the bottom, even WHO guidelines, if you can, use single pill combinations. But if we now go to the guidelines, top left, ASH, that's about 2013, 2014, up to 2020, and you stratify them by ethnicity. And I put the Black patients along the top and non-Black along the bottom. And what you see basically is chaos. There is no consistency for Black patients and there's no consistency for non-Black patients. All in the guidelines, all looking at the same data. And the reason that happens is that we don't have good evidence for Black patients, nor do we have good evidence for patients from South Asia, the Indian subcontinent, a massive proportion of the world society. So they're the things that we are recommended, but what you can see, it's 1, 2, or 3 of, on the left-hand side, top left, it's A plus C or A plus D or C plus D. They are the evidence-based combinations that we've got recommended to use, whether you're Black or whether you're white. Let's just have a quick look at those. Let me remind you again, A is ACE or ARB, D, diuretic, dead easy. And here you see the 5 trials that have informed the recommendation to use A plus D. Life, losartan plus hydrochlorothiazide versus B, beta block, atenolol plus hydrochlorothiazide. And these were hypertensives who've got LVH on their ECG or echo. And in that trial, the losartan plus hydrochlorothiazide was better than atenolol plus hydrochlorothiazide. It was better for stroke. It was not better for coronary artery disease. And we know that atenolol is not very good at preventing coronary artery disease either. So that's a pretty empty victory, but nevertheless, it is evidence that ARB plus thiazide diuretic is superior to atenolol plus thiazide. Next value is valsartan plus hydrochlorothiazide versus amlodipine, C, calcium channel blocker plus hydrochlorothiazide. And that was a tie. There was no difference between the two. If you want to cherry pick, then you'll see that the amlodipine was superior to the valsartan in coronary disease. Long story about the ARBs not being as good at coronary protection, and certainly the value contributed that. Then the next three, progress was post-stroke, HIVET, the very elderly, that was age 80 and above, and advanced type 2 diabetes, in which case the A plus D there was perindopril plus indapamide, a thiazide-like diuretic, not a thiazide, thiazide-like. So in all three of those, it was perindopril plus thiazide-like diuretic against placebo. And in all three of those, there are significant benefits associated with treatment. So post-stroke, very elderly type 2 diabetes, evidence that A plus D works. And the A was an ACE inhibitor. Now, if we want to go to C plus D, the evidence is pretty limited. That's calcium channel blocker plus diuretic. That was in the value trial, and that was equal to the A plus D. But that's really the best evidence we've got for C plus D. I'll mention it in blood pressure lowering because it's good at that, but in terms of vascular protection, not in a laboratory, but in real lives, counting heart attacks and strokes is what matters. So now we turn to A plus C. So that's ACE inhibitor or R plus calcium channel blocker. There are two trials, ASCOT, perindopril plus amlodipine against a beta blocker thiazide, and ACCOMPLISH was ACE inhibitor, benazepril, which we don't have in UK. I don't know if you have it here, do you have benazepril? No, you don't in UK. But it was benazepril plus amlodipine versus benazepril plus thiazide, and the amlodipine was superior to the thiazide. All the A plus C data is ACE plus calcium channel blocker. It isn't ARB. There are no trials of ARB plus calcium channel blocker. And yet it's there in some of those guidelines. You saw it in the European guidelines. First line therapy, ARB plus CCB as a possibility. No trial evidence it works. I don't understand that. But nevertheless, that's the evidence we've got. So just let me take you back to those guidelines stratified by ethnicity. And on the basis of that, I thought it was critical that we found out what the best combinations of drugs were by ethnicity around the world. So that was the design of what I hope is going to be three big trials. The ethnic groups subdivide, randomized, R for randomized to get A plus C or A plus D or A plus C. And we've done that in sub-Saharan Africa. That was the Creole trial. And I'll show you the data. South Asian, that's work in progress. That's the top spin trial, which is happening now. And next year, we hope to start in the Far East to at least discover what the best blood pressure lowering agents are in combinations. Hitherto, there was no such evidence around the world. All right, so there you see it. In Africa, we had Creole, South Asia, the top spin. Creole, the idea was that you got better blood pressure lowering Black patients if you use calcium channel blockers and diuretics when they're used as monotherapy. So we reckoned if you put them together, CCB and diuretic, you'd get better blood pressure lowering than CCB plus ACE or ACE plus diuretic. So our aim, we didn't have enough money to go for cardiovascular outcomes. We wanted to compare the efficacy of those combinations. Amlodipine plus hydrochlorothiazide, amlodipine plus perindopril, and perindopril plus hydrochlorothiazide. They were the three combinations, and the primary endpoint was 24-hour ambulatory systolic blood pressure. That's all we could afford. And the answer was that amlodipine plus the thiazide and amlodipine plus the ACE inhibitor lowered the blood pressure better than the ACE plus the thiazide. So two of the three groups were about the same, and they were better than the ACE thiazide in the Black population. Now those amlodipine hydrochlorothiazide and amlodipine perindopril, pretty similar blood pressure effects, and they got slightly different side effects. The ACE inhibitor obviously caused increased cough and angioedema, whereas the thiazide caused hypokalemia, and they were pretty mixed in terms of proportions. So you take your choice. And our final bullet there was that pending trial evidence on cardiovascular outcomes, the Creole data may be useful to influence you in your choice of antihypertensive drug selection for Black patients, at least in sub-Saharan Africa, because that's where the trial was. Right, let's come back to which ACE. Are you going to use an ACE inhibitor or an ARB? Well, this is what the International Society of Hypertension said a couple of years ago. Randomized trial benefits between ACEs and ARBs were not always identical. In fact, they were very different in different patient populations. So the choice between the two classes of RAS blockers, ACEs and ARBs, depend on the patient characteristics that were investigated in the trials, on availability, and on cost and patient tolerability. So they're going to cause influence, and patient tolerability matters. The ARBs cause a cough. I beg your pardon, the ACEs cause a cough. Okay. So let's turn to the meta-analyses of all-cause mortality comparing ACEs and ARBs. And here you see 4 meta-analyses: hypertension, diabetes, coronary artery disease, and high-risk patients. The impact on all-cause mortality. The dark blobs are the ACE inhibitor, showing significant benefits in all 4 meta-analyses. The gray blobs show no benefit whatsoever. That's the ARBs. On the right-hand side, no benefits on all-cause mortality. Well, you may be cynical about meta-analysis. I am sometimes, because it depends what goes into the mix. But that worried me. But if we now, and we don't have time to look at all the relevant trials, if we look at different subgroups of patients, what I'd like to persuade you is the title there is the truth. That is that the ARBs, the data on the ARBs is missing or it's failed, where the ACE inhibitors have succeeded. So at the top, the HIVET trial, that's the very elderly, 80 plus, using indapamide and in a proportion perindopril against placebo. The red blobs show a significant benefit. Primary endpoint, all-cause mortality, and because of all-cause mortality, the trial was stopped earlier and we didn't have time to look at cardiovascular mortality in HIVET. What evidence is there on the ARBs in the very elderly? Correct, none. But it's there for the ACE inhibitors. Right, the HOPE trial, everybody knows the HOPE trial. This was a high-risk population getting ramipril at night against placebo. Big significant benefits right the way across the board there. So if it works in high-risk patients with the ACE, let's do it with a long-acting ARB, telmisartan. So they did. And you see the benefits. There were none. Telmisartan, high-risk patients, no significant benefits. It worked for the ACE inhibitor, but not for telmisartan. So now let's go to post-stroke, PROGRESS trial. The PROGRESS trial, people who'd had a stroke, they got, oh, thank you. That's better. They got perindopril, and in a proportion, they got indapamide. It was slightly strange analysis or design, I beg your pardon, but recurrent stroke was significantly reduced by the ACE plus indapamide. 28% reduction in recurrent stroke. The ARB, it worked in the ACE inhibitor, so let's use a long-acting ARB. Telmisartan, PROFESS trial, post-stroke. Look at it. No benefit. No benefits post-stroke. 5% non-significant reduction versus 28% with the ACE inhibitor. You then go to the ADVANCE trial in type 2 diabetes. Big, significant benefits using, this was a single pill combination of perindopril indapamide, red across the board. Big benefits. What have you got in type 2 diabetes with the ARBs? You've got lots of early data with the ARBs on proteinuria. But at the risk of upsetting nephrologists amongst you, I think proteinuria is fool's gold. What matters are the bodies, the heart attacks and the strokes and the deaths. And what happened in the roadmap trial, the one perhaps you can't see at the bottom, roadmap was olmesartan versus placebo in patients with type 2 diabetes who did not have proteinuria. The primary endpoint was the appearance of proteinuria, and olmesartan was better than placebo at microalbuminuria. Okay? But what happened for those randomized to olmesartan? They had a 5-fold increase in cardiovascular death compared with placebo. Now, the numbers aren't huge. It was statistically significant. It was 15 versus 3. As cardiologists, you probably care about sudden death and MI. That was 12 if you're on olmesartan and 1 if you're on placebo. So as I look at that, allied with the fact we're recommending A plus C, and there are no ARB plus calcium channel trials, I think the top line is very fair. ARBs are found missing or they've failed where the ACE inhibitors have succeeded. And I won't bore you to death with all the guidelines, and here they go right back to the on-target trial, which even though there was apparent equivalence in the on-target trial, the FDA said, use ACE inhibitors preferentially. Coming right the way down, I could repeat all these, but I won't, till down here at the bottom, 2021, the WHO guidelines. The WHO guidelines in 2021 gave ACEs and ARBs equivalence in their guidelines because it was simple and easy. But their own data in that document said that mortality was significantly reduced by ACE inhibitors, 23 per thousand, but not by ARBs. And behind the gentleman there is 14 per thousand, half the death rates. And WHO says they're equivalent. Well, I know which I'd want to give to my brother, sister, mother, father, anybody else. I don't understand how they are given equivalence in the European guidance, for example. I just don't get it. Now, this is much easier. Which calcium channel blocker? Amlodipine, dead easy. Amlodipine has got all the evidence. It's the best long-acting agent we've got. What does it do? It gives you ankle edema. That's the problem with it. There are those who are interested in proteinuria will say that the normal amlodipine doesn't reduce proteinuria. Correct. It does reduce heart attacks and strokes and deaths. And as we mentioned earlier, on the different calcium channels, there are some drugs now that work on different calcium channels, and they don't put your creatinine up, and they do reduce proteinuria. So there are some calcium channel blockers around the corner, but no evidence of cardiovascular benefits. And we should not be, in my opinion, using drugs that don't have large-scale morbidity, mortality evidence. So I think this is dead easy. We should just be using amlodipine. It's the most effective drug we've got. It's got the longest duration of action. And there's a shed load of randomized trial evidence what we should be using. Which diuretic? Well, I mentioned earlier, there's confusion amongst doctors, and it's not surprising because the American guidelines mix up the two. They call thiazides, and that's a mixture of thiazide-like and thiazides. And then they say thiazide type, just to really get everyone confused. But I think they should be looked at separately. What is a thiazide? A thiazide has got it in the name. If it isn't in the name, it's not a thiazide. So hydrochlorothiazide is a thiazide. Short-acting agent, hydrochlorothiazide, doesn't act for 24 hours. Indapamide and chlorthalidone are not thiazides. They are thiazide-like. But that first bullet there was a shock for me. I reviewed all this data. It's over 10 years ago now. Nothing's changed. And that is, there is no evidence for the benefit of truly low-dose thiazides against placebo in terms of cardiovascular events. None. What do we mean by low dose? Thiazides up to 25 milligrams of hydrochlorothiazide. That's low dose. Previously, we had high dose thiazides, and they did prevent cardiovascular events, but as I'll say, they cause problems. So no evidence for low dose thiazide, which is what most people use around the world. No evidence for it. But then we go on to the low dose thiazides when they've been compared with anything else. 3 trials, low dose thiazides have been shown to be inferior to comparator drugs. What we do have good evidence for amongst the diabetics, the diuretics, is high dose thiazides, which we've all given up using because of the metabolic adverse effects. You have a huge amount of type 2 diabetes here. Your patients don't need any assistance in getting diabetes. So we've stopped giving high dose thiazides basically. And they also, they need potassium supplements very often. So then you're left with 2 drugs down here, which are the thiazide-like diuretics. which are different. They're different chemically, they're different in terms of their outcomes. And just in case you think it's just me, this is what the 2018 European guidelines said. Chlorthalidone and indapamide have been used in a number of trials showing cardiovascular benefits, and they're more potent than hydrochlorothiazide in lowering blood pressure with a longer duration of action compared with hydrochlorothiazide and no evidence of increased side effects. Lower dose thiazide-like diuretics also have more evidence from RCTs demonstrating reductions in cardiovascular events and mortality when compared with lower dose thiazide diuretics. So thiazide-like have got the evidence and thiazides don't. But what do we use? Thiazides around the world. If we started again, there would be no question. No one would use low-dose thiazides. They don't have the evidence to support it. The good news is that when we finish up needing 3 drugs, onto triple therapy, all the guidelines, not necessarily in that order, but when you're onto 3 drugs, A plus C plus D, everyone agrees. The only debate is what A, and I've given you my opinions, and what D, I've given you my opinions. But all the guidelines, triple therapy is A plus C plus D. Now, what's the best 4th line? Well, the evidence, randomized trial evidence for the best 4th line agent is spironolactone at low dose. You can get away with 12.5 milligrams, but I usually start at 25 milligrams. You've obviously got to watch the potassium and the creatinine. But in general, these are fantastically effective drugs, and kept at low dose, they're also well tolerated. So that's 4th line, spironolactone. If that's not enough, then my favorites are down here. 5th line, I use doxazosin in its slow release formulation. We heard from Professor Mancha that doxazosin in the elderly, if you give the ordinary formulation, people are gonna fall over and break their hips. The slow release doxazosin doesn't do that to anything like the same effect. And then last line is the beta blockers. For the reasons that we heard, there is no evidence really compared with any of the other agents. They prevent cardiovascular events. Good in the laboratory, some of them, but no evidence except in heart failure for this drug class to be used. So I have them last. Now, in my opinion, you probably don't care about my opinion, but I've come all this way, so I'm going to give you my opinion. I think spironolactone is a great 4th line agent. I actually tend to use doxazosin before spironolactone because with doxazosin, you don't have to check anything. It's very good for the men, prostates, etc. Erectile dysfunction is one of the benefits that was shown a long time ago compared with the other drug classes. So I tend to go 4th line, doxazosin, and then I add in spironolactone. And if you can't get them controlled with that, I would question whether they're taking their tablets. All our patients, all of them, if they're on 3 or more drugs, we send their urine off for the drug metabolites to check whether or not they're actually taking their tablets. And I'm horrified to say that 25% are taking none, and another 25% are taking less than they're supposed to be. So that's a worthwhile test on our patients. Finally, I'd just like to bring you to this table of the ISH guidelines, the ideal drug characteristics. And I think if we use this as a guideline to how we manage our patients, we'll be doing the right thing. Treatment should be evidence-based in relation to morbidity and mortality. We've got enough drugs that that's the case, that's what we should use. And we want drugs that give full 24-hour blood pressure control, not drugs that have gone at 20 hours. We don't want that. The treatment obviously should be affordable and or cost effective compared to the other agents available, and they should be well tolerated. And that's why we can come to the question about the ACE inhibitors, that no doubt they cause a cough, and ARBs don't cause a cough. But ARBs don't prevent all-cause mortality in the vascular events either, in my opinion. And finally, I think we want evidence of benefits of use in the medication, the populations to which it is to be applied. Good randomized trial evidence. If we get that, we'll be looking after our patients properly. Finally, this goes back to a quote for 20 years now, and it basically says, based on ASCOT, we should be giving our patients a statin. Doesn't matter what their lipid levels are. You can do cardiovascular risk if you like, but they should be receiving a statin. And that was the status who said you need 10-year cardiovascular risk of 20% or more, they should be on a statin. Well, that's come down now to a 10-year cardiovascular risk of 10% or more, they should be on a statin. No brainer. The great thing is you don't have to think. Just give a statin. Atorvastatin, 20 milligrams, fantastic, in primary prevention. And coming up to date, the European guidelines said, use statins in hypertensive patients with moderate to high cardiovascular risk, which is just about all the men and anyone over the age of 50. Finally, Chairman, ladies and gentlemen, this is how we have traditionally managed hypertension. We get hold of an arm and we squeeze it. And then depending on how high the mercury column goes, we dish out tablets, but we ignore the object attached to the arm. And the object needs a few things dealing with. Got to cut out the smoking, cut down the alcohol. He's pregnant. There are all sorts of things that need dealing with here. And just by handing out blood pressure tablets, we are not going to save cardiovascular events effectively. We have to take a global view. Thank you for your attention.
Thank you, Professor Neil, for these very comprehensive illustrations of the recent updates of combination therapy in several subsets of populations. My question is about patients who developed a hypertensive emergency despite his routine management of certain medications all the time. After this event, would you like to change the classes of antihypertensive medication, increasing the dose, or re-evaluate the patient once again?
Well, that's a really good question. The small proportion who do go to an emergency or an urgency, if it's an emergency, they need treatment. Got to get the blood pressure down pretty quickly, and you use different agents. Very often, as I think one of the cases we heard earlier this morning, they weren't taking their tablets. You remember the 34-year-old lawyer who had had a 5-year history of hypertension this morning we were told about? He came in with an emergency and he wasn't taking his tablets, almost certainly, and hadn't done for several years. So I think that's one of the problems. And I think in routine follow-up, there are very rarely, so long as we're following our patients up once they're stabilized every 6 months, every year, which is what we should do, there's very little opportunity for an emergency situation to arise. It does occasionally, but I do take your point. And we've got to look for secondary causes in that situation, particularly if they're young. But then you just do what you can to get the blood pressure down in the relatively short time. I think one of the slight surprises is there's a danger in dropping the blood pressure quickly in the urgent situation. Emergencies, you've got to get in there and do it within some hours. But the urgencies, you don't necessarily have to bring them into hospital. It needs to be done over a few days. And we tend to use, interesting, very low dose of beta blocker, or alternatively, we'll use amlodipine or slow release nifedipine in those situations in the acute setting.
Any question from the floor? Yes, please.
Very thanks for this lecture. Actually, it is very beneficial for me and I think for all. Please, I have a question about regarding specific medications for Black peoples and not Black peoples. Many times I ask this question: who's those Black patients? I am to apply this for my work. I'm working in south of Egypt in Aswan. I have a Black peoples, I have Nubians. Is Black peoples in America in different culture, in different history, who tolerated water sort of retention, their grandfather and genes, to be in America, like those peoples I live with in South Egypt? What mean by Black? Black equal what? Equal melanin, equal food?
Equals what?
Equal.
Yeah, great question, great question. It equals renin level. That's probably, it's a surrogate for the renin level. Black patients, the ones in America, the ones in sub-Saharan Africa, the ones in London, tend to have very low plasma renin.
In different culture and
Different
food.
cultures, absolutely different, low renin. They have low renin levels. And that's pretty much standard. If you have a black patient with a high renin level, look for renal artery stenosis, because the vast majority, they're low. And in our setting in London, which is a whole range of people, they are below scale. And so the aldosterone renin ratio is always high. Everybody panics and says, it's cons. It isn't. The aldosterone is quite normal, but the ratio becomes very high because the renin is so low. But the answer to your question is, it's not melanin, it's not the culture, it's plasma renin. It's a surrogate for plasma renin. In the same way that old age is used to dichotomize how we treat. You know, the old British guidelines, if you are 55 and above, which I'm sad to say was called old, if you're 55 and above, you use a calcium channel blocker or a diuretic because their plasma renin levels tend to be low. And so the beta blockers and the RAS blockers don't work as well in older patients.
Thank you.
Pleasure.
Thank you very much. Thank you, dear Professor.
Neil, thank you. Because of you, we are resetting our mind regarding the use of angiotensin receptor blocker. In this country, sometimes we use ARBs routinely post-myocardial infarction without real indication. Do you believe in ARBs paradox? In the roadmap trial, olmesartan was associated with more myocardial infarction.
Yeah.
What do you think about that?
I think the coronary society guidelines have been consistent in saying you should use ACE inhibitors first in the post-infarct setting before ARBs. And if you can't tolerate the ACE, try the ARBs. So I think we should. It may be that in the context of type 2 diabetes, the ARBs are particularly bad. I mean, it was against placebo, but it stopped me using ARBs in the context of type 2 diabetes. I cannot, with my hand on the heart, see a new patient with type 2 diabetes and say, here's an ARB because you won't cough. That's the problem. We're worried about causing a cough. Well, it's true, the ARBs don't cause a cough, and nor does placebo. So I think a rethinking about around the ACEs versus the ARBs is appropriate.
Thank you, dear professors.
Thank you.
Before closing the session, I want to congratulate the president of the 25th annual hypertension meeting, Professor Ahmed Abdelghani, and of course, the founder of the Hypertension Society, Professor Mohsen Ibrahim, who really did the screening, the first screening for hypertension, and upon which all the studies came up later on. Thank you very much.